Asian Heart Society has prepared a truly exciting program consisting of 8 specialty forums from Asian Heart Society councils, namely interventional cardiology, hypertension, arrhythmia and electrophysiology, heart failure, structural heart disease, basic and translational science, cardiovascular prevention, and cardiovascular surgery. Multiple parallel channels, hot topic debates, controversial case discussions, and deep dive sessions that go beyond the standard presentations. Lively, interactive discussions designed to spark cross-disciplinary dialogue and bring more value and more voice to the table. Please do not miss to attend the Asian Heart Society Research Summit 2026 to learn directly from Asia's leading experts and gain practical, battle-tested insights. To stay updated on the latest cardiovascular breakthroughs, to directly explore topics of interest across multiple channels, and to watch top minds challenge each other in dynamic case debates. Look forward to seeing you all in the Asian Heart Society Research Summit 2026 this coming weekend. I thank you for your attention. Dear colleague, dear friends, as the president of the Asian Heart Society, I'm thrilled to announce that the Asian Heart Society Research Summit 2026 will take place on July 4 to 5 virtually. Asian Heart Society has prepared a truly exciting program consisting of 8 specialty forums from Asian Heart Society councils, namely interventional cardiology, hypertension, arrhythmia and electrophysiology, heart failure, structural heart disease, basic and translational science, cardiovascular prevention, and cardiovascular surgery. Multiple parallel channels, hot topic debates, controversial case discussions, and deep dive sessions that go beyond the standard presentations. Lively, interactive discussions designed to spark cross-disciplinary dialogue and bring more value and more voice to the table. Please do not miss to attend the Asian Heart Society Research Summit 2026 to learn directly from Asia's leading experts and gain practical, battle-tested insights. To stay updated on the latest cardiovascular breakthroughs, to directly explore topics of interest across multiple channels, and to watch top minds challenge each other in dynamic case debates. Look forward to seeing you all in the Asian Heart Society Research Summit 2026 this coming weekend. I thank you for your attention. Dear colleague, dear friends, as the president of the Asian Heart Society, I'm thrilled to announce that the Asian Heart Society Research Summit 2026 will take place on July 4 to 5 virtually. Asian Heart Society has prepared a truly exciting program consisting of 8 specialty forums from Asian Heart Society councils, namely interventional cardiology, hypertension, arrhythmia and electrophysiology, heart failure, structural heart disease, basic and translational science, cardiovascular prevention, and cardiovascular surgery. Multiple parallel channels, hot topic debates, controversial case discussions, and deep dive sessions that go beyond the standard presentations. Lively, interactive discussions designed to spark cross-disciplinary dialogue and bring more value and more voice to the table. Please do not miss to attend the Asian Heart Society Research Summit 2026 to learn directly from Asia's leading experts and gain practical, battle-tested insights. To stay updated on the latest cardiovascular breakthroughs, to directly explore topics of interest across multiple channels, and to watch top minds challenge each other in dynamic case debates. Look forward to seeing you all in the Asian Heart Society Research Summit 2026 this coming weekend. I thank you for your attention. Dear colleagues, dear friends, as the president of the Asian Heart Society, I'm thrilled to announce that the Asian Heart Society Research Summit
Hey, good morning. Welcome to the 2026 AHS Research Summit. This is the last session of the this year's summit, and this session we will discuss about the techniques and experience of transcatheter, the valve replacement and repairment. I'm Dr. Do Gang from Asa Medical Center in Korea, and I'm now working in Asa Medical Center as an interventional cardiologist. And my co-chair is the Jing Chen from Renmin Hospital of Wuhan University, and Kent So from the Chinese University of Hong Kong, and he's working in the Prince of Wales Hospital. And another co-chair is the Liang Guo from the First Hospital of China Medical University, all working as the active interventional cardiologist. And today we will share the 4 lectures all about the techniques and experience of the transcatheter valve treatment by the 4 very experienced and distinguished speakers. The first lecture will be delivered by Dr. Jonathan Yap from National Heart Center in Singapore. He will talk about the transcatheter TAVR with a step-by-step guide. And Jonathan Yap, he is the clinical associate professor and the senior consultant in the National Heart Center Singapore and director of structural heart intervention. He's a very active and very excellent operator and speakers, and also my teacher and my good friend. And I will introduce the Jonathan Yap. Can you please give a lecture? Thank you.
Thanks, Duyun. Thanks, Duyun. Yeah, so it's nice to come and meet good friends again. Very good morning to everyone. Today I'm supposed to give a talk on transcable TAVR, a step-by-step guide. And I think this is a very interesting topic that I hope will interest all of you. So this is the outline of my talk. I will give you a little bit of the principles of electrosurgery, and then we'll deep dive direct into how we do transcable TAVI in a step-by-step fashion. So just a couple of slides on the principles of electrosurgery, because it's very important to understand it if we want to perform electrosurgery. So number one, if we want to do electrosurgery, we need a circuit. So a positive circuit, which is the pen, and then we need a grounding pad. And all these are attached to the electrosurgical generators. In the rest of Asia, I'm not sure in China, but we use this Bovi pen, whereby there's a yellow and a red button to press. The red button, the blue button, sorry. The blue button, when you press, it's a coagulation. You can see the energy is delivered in pulses. That's not what we want. We want the energy to be delivered almost constantly. So that's the yellow button, cut. So when we do electrosurgery, we always press the yellow button. As you can see, the energy delivered is constant. There are two main uses of electrosurgery. One is to cross tissues. So it could be doing a transeptal that's the interatrial septum is very thick, transcaval, which we are going to talk about today. And the other use, and there's quite a lot of prominence in these recent months, is tissue laceration, whereby we cut tissue. We could be cutting mitral tissue, we call it lampoon, or cutting aortic tissue, basilica, or cutting the myocardium, sesame. So how do we set it up? It's similar in all kinds of cases. At the end of your wire, you will remove the coating, and then you attach this electrosurgical pencil, or the Bovi pen, as we call it, with a forceps. At the end of the wire, there will be a microcatheter to insulate it. If you look at the bottom diagram, you can see that without the microcatheter at the tip, the energy is very weak. But if you advance the microcatheter all the way to the tip, you really concentrate your energy, allowing you to burn through the tissue. So today, our main focus is on transcaval TAVI, whereby we cross from the IVC into the aorta to perform TAVI. So I'm just going to go through a couple of important steps, and I hope that you'll be able to learn from them. And nothing better than using a case to highlight the different steps. I had an 80-year-old gentleman with diabetes, hypertension, and hyperlipidemia. He had laryngeal cancer and was on a tracheostomy. He had AF and had some PCI done for non-STEMI. He came to see me for worsening breathlessness, and on echo, it showed severe AS with a gradient of almost 50 millimeters mercury. This is his CT scan. His annular area was about 426. As you can see, the coronary heights were okay. But I think the area of interest was the peripheries. If you look at his femorals, they were all below 5 mm and very calcified. So it was about 4 on the right side and also about 4 on the left, and you can see the amount of calcium was very, very bad. So we looked at other sources. If you look at the subclavians, they were also very small and calcified. And we was looking at direct aortic, but he had a tracheostomy there, and there was a lot of phlegm coming out, and so it will really not be good. And so the plan was to do a transcaval TAVI with a 23 millimeters Edwards Sapien 3 overfill. And the idea of transcaval is this: if you make a connection between the aorta and the IVC, because the aorta has higher pressure compared to the IVC, so there'll be a shunt bleeding direct from the aorta to the IVC, and you will not go out into the retroperitoneal space. And so that's why it's supposed to be safe. So these are the different steps that you all need to know. I think the most important actually is number one, CT planning. As with TAVI, we know if we plan our cases well on CT, it goes smoothly. And so likewise for transcaval, CT planning is extremely important. There are 4 main steps to CT planning. Number one, we need to identify the correct and good spot for puncture. We need to confirm our fluoroscopic angles and anatomic landmarks, and we need to plan our bailout strategy. So to identify your site of puncture, you need to scroll up and down your CT scan, and you need to find a spot where there's no calcium and mark it. And this spot has to be below the renal arteries and above the iliac bifurcation with a bit of distance, so that you have enough space to put your bailout stent if needed. So in this case, I mark this space here called marker 4, and you can see that this is the spot where there's not much calcium. Next, we need to identify our angles of entry. So you draw a line where the marker 4 is. You draw a line from the middle of the IVC to the middle of the aorta, and then you draw a 90-degree line downwards. And so this gives you your angle. Over here, 75, that's LAO. And you just go 90 degrees anti-clockwise for the orthogonal angle, RAO 15. So you got your 2 angles, LAO 75, RAO 15. Next, you need to identify the bony landmark so that, on fluoro, you can understand where you are going. So where marker 4 is, you can see it's here at the top of L3 vertebrae. So you can count from the spine. This is L5, L4, L3. So the L2, L3 intervertebral space is a good spot to aim for. Lastly, you want to look at the size of the aorta where you're puncturing, just in case, you cause a constant bleeding, you need a bailout stent. So you need to size your bailout stent just from the CT measurement. So that's the other important part. Okay, next up, we go to the equipment. These are the list of important equipment that you need to prepare. So to cross from the IVC to the aorta, you need one of these guides. You can use the RDC guide, a JR4 guide, or IM guide. It's up to you, whatever you have on your shelf. But you need a guide that's short, not the standard coronary length. I think so about the 70 cm will be great. You need a long estato wire, about 300 centimeters. And you need 2 microcatheters, the 014 microcatheter. In Singapore, we use the Fine Cross. And then the 035 microcatheter, which we use the Navicross. That's in the IVC. For the aorta end, you need a gooseneck snare with a JR4 guide to put as the target to aim for. And to close off the hole eventually, you need an edgeless sheath. We call it ADO, which is a PDA occluder by Abbott. 10-8 usually used. Some standby balloons to tamponade and some covered stents. In terms of the balloons to tamponade, these are what's available in general. You can use the M-Plat sizing balloons or the Tyshek balloons. But please note that the size of the introducer that's required, because most times the femorals are already diseased, so you may not be able to put in such a big sheath. Also, you need to prepare your covered stents. Once again, the B grafts tend to be more used because, it just requires an 11 French sheath. And most of your arteries are diseased and may not be able to take too big a size, okay? So for vascular access, what do you need? In this case, we went from the right femoral vein as our main site. We pre-closed it. The other femoral vein was used to put the temporary pacing wire. And then you need to choose the better site, whether the right femoral artery or the left femoral artery is better, because you still need a small arterial access. And in this case, the right femoral artery was not as bad as the left, and we used it as our main arterial access site. And the 5 French on the other side, just as a backup in case we need it. Next up, the trans cable itself. Let me show you how we do it. So first, we do a IVC gram, just to see the relationship of the IVC and the aorta. So we concurrently inject a pigtail in the IVC as well as the aorta. This is not always required, but if you're starting off, I think it's good to understand some of this anatomy. And next, we identify the landmark based on the bony landmarks that we measured on CT on where we want to cross. This is how we set up the thing. In our guide, there's this 035 Navicross microcatheter. Then there's a 014 microcatheter, in our case, Fine Cross, and then there's the tip of the estato at the end of it. Then at the end of the estato wire, we remove the coating and we put the electrosurgical, or we call it Bovie pencil. So this is how it looks like. If you look at the fluoro, in this case, we have, I think this is RDC that I used, RDC guide. And my microcatheters are at the tip. And then this is my wire. And then in the aorta, I have my JR4 guide with the snare. So I position it at the L2, L3 intervertebral space. I have my LAO75 angle as well as my one fast angle. And then the snare provides you a target to aim for. And so you electrify at about 50 watts, very short burst. The moment you cross, you stop the electricity. You don't want to go through and through your aorta. So in this case, you can see we put from the aorta to the IVC and through into the snare. And so we snare it. We snare the estato wire. We bring up the snare all the way up to the aortic arch. And after that, we push in the different microcatheters. We bring in the 014 microcatheter first. And then after that, we bring in the 035 microcatheter. And after that, we take everything out. And in the 035 microcatheter, we put in a stiff support wire, the Lunderquist. So after that, we bring in the sheath of the TEVI from the IVC all the way into aorta over the stiff wire. And then you should suture your sheath in because you don't want the sheath slip back from the aorta to the IVC, and then you will bleed from the aorta into the retroperitoneal space. So you must make sure you suture the sheath in so that the sheath does not move. So after that, it's a standard TEVI. You cross the valve, we balloon the valve with a 16 mm balloon. We deployed Sapien 23 millimeters. We overfilled a little bit. And then you can see this is the final aortogram. So after your TEVI sheath goes in, it's a very standard TEVI. And then the main part comes, actually the most difficult part after that is the closure. So how do we close the hole? This diagram here kind of illustrates exactly what you need to prepare. So this is the TEVI sheath. Inside the TEVI sheath, we put in an Agilis small curve. And inside the Agilis, we have our plug. In this case, it's an ADO 1018. And inside the sheath also, I have a safety wire, a long safety wire, just in case I lose access, I still am able to get in. And in one of my arterial access, I have a pigtail so that I can inject in the aorta to see. And on the other side, you can see a safety balloon parked in the iliacs, just in case I need rapidly to tamponade the hole. I've got the safety balloon there. So this is how you should set your system up. And of course, at the back on your shelf, you need your covered stents just in case it doesn't work. So this is what happens. You reverse heparin. You quickly pull back the aortic sheath all the way down to the IVC. Don't leave it stuck in between, then it will bleed into the retroperitoneal space. So we withdraw the sheath completely into the IVC. And you can see in the diagram how I flex the Agilis to make it coaxial with the hole and deploy the ADO plug. So this is unsheathing the disc of the ADO plug and pulling it so that it's a butting thing, and then you finally deploy the ADO plug on the last angiogram image. So this is a step of how we flex the Agilis sheath and make it coaxial, pull back a butt on the aorta, and then deploy the whole device. So there are different kinds of leaks that can happen after you deploy this. One, you totally occlude. One, you still have a little bit of a leak, but it's true and true. There's no extravasation in the retroperitoneal space. Two, we call it cruciform. You can see a little bit of extravasation. This one, you need to observe a bit. And then lastly, you see frank extravasation, which is bad. So normally, if you have 0 or 1, it's great. You can leave it alone. You don't have to do anything. So in this case, in our patient, I did the aortogram. You can still see a shunt from the aorta to the IVC, but this is a type 1, and it's actually acceptable. But in our case, we just wanted to be a bit extra safe, so we gently hand inflated. Don't use a indeflator because you may rupture things. Just hand deflate. Your hands don't have as much strength. We hand inflated the 18 mm balloon over the device just to flatten it against the wall a little bit and get some apposition for a few minutes. After that, it kind of looked the same anyway, so we left it alone. Let's use type 1 leak, which is acceptable. And so this is the this is the final shot of the right iliac. So where we went up, it looks pretty decent. You can see how bad the peripherals are. So patient did well and was discharged in a few days. So just in summary, transcaval access is a potential alternative access consideration in patients with prohibitive iliofemoral access. Careful CT planning is crucial. You need to make sure you have the detailed equipment list as well as standby bailout plans. And then if you plan and analyze carefully, transcaval access may actually be able to be performed safely and successfully. Thank you.
Thank you, Dr. Ya, for the very practical walkthrough. Actually, the transcaval access sounds very difficult and intimidating at first, but your step-by-step approach shows it can be very easy and systemized. Actually, in the current era, with the smaller sheath profiles and alternatives like transaxillary or transcarotid access, then which patients do you still consider the ideal candidates for the transcaval approach?
So, in my center, we are not so, as I said, we don't really go crazy on doing transcaval and all that. So we really reserve it for the patients where our second line is subclavian or transcarotid. So if that's not possible, then our third line will be transcaval. And in this patient's case, for example, his subclavian was very small and he had a tracheostomy with radiation to the neck. So both the subclavians and carotids were not available to access. And so these are the kind of patients, at least at my center, where we do the transcable for.
Then, any other moderators and lecturers have any comment or question?
Dr. Yap, thank you for the presentation. So I have a question. How about the anticoagulation after the procedure?
You don't have to anticoagulate, so it's standard TAVI therapy. So usually we just give single antiplatelet. So the blood thinners is mainly for the TAVI valve. So for the transcatheter access in particular, you don't have to give anything extra. For patients on anticoagulation, we sometimes get a little bit worried. I've heard from the experts that it's okay, but we may delay starting it like by 1 or 2 more days just to let any bleeding kind of subside first.
I think the most important part is the occlusion. So
Yes.
If the occlusion failed, we can use the curve stents in the aorta. Do you
Yes.
use another curve stent for the IVC?
No. So if you look at the series of data and if you speak to the founders of the transcable methods, covered stents, in their experience at least, because they have done close more than hundreds, it's very rare. What they find that works best is the balloon, the tamponade balloon. If you go up a few times, majority of the bad leaks will actually stop. So you reverse heparin, you put up your tamponade balloon for 10, 15 minutes, majority will stop. In their experience, less than 1% requires covered stent. And if you are putting a covered stent, you only need to do it on the aortic side. You don't have to do it on the IVC side.
Okay, thank you.
Okay, 10 to 15 minutes for
Yes.
the balloon tamponade.
Yes.
How long did you do for your case?
Yeah, my case, it was type 1. Actually, it was acceptable.
Yeah.
But as I said, we were just, this was one of our first cases, so we were a little bit worried, and we actually just went up another 5 minutes, and it kind of looked the same, and we stopped. Yeah.
Okay. Oh, yeah. That's a very interesting case, and the tips and techniques for the transcatheter approach. Actually, it's not for everyone, but we should know and prepare for those patients. Yeah. Okay. Thank you,
Thank you.
Jonathan. Yeah. Okay. The next lecture will be delivered by Dr. Liang Tang from the second Jinja Hospital in Central South University. He will talk about the proceedings in Lidu Tower. He is the associate professor and deputy director of the Department of Cardiology in the second Jinja Hospital in Central South University. And he is the very active investigators and operators in structural heart intervention. And Dr. Tang, please, go ahead.
Okay. Good morning, moderator and the colleagues joining us online. So I will share my PowerPoint.
Okay.
Sorry. Okay. I'm difficult to share my PowerPoint.
Okay, take your time.
I'm sorry. My PowerPoint.
If you have I cannot see yet.
Excuse me，不好意思，唐教授，您可以尝试一下，先打开 PPT 在这个桌面上，然后再进入。
我已经打开了，就是没法没看到那个共享屏幕。
您是白页版的话，下面会有一个公布或者公开，应该是公开。
公开，耶。
那公开就是共享。
公开。 你看，我打开了我的 PPT 在桌面上了。对，
If you
看一下，它有一个公开，那个公开点开之后和这个共
可以
享。
看到了吗？请问
actually still not。还是没有的。
公开了，刚刚看了闪了一下，对，共享。
sorry， you
Yeah.
just muted。唐教授，您开一下麦，现在可以看到您的共享了，是没有问题的。唐教授，您静音了，您开一下麦。
Okay, we can see the slide well, but I cannot hear you. You're muted.
Oh, can you hear me? Sorry.
Yes, I can hear you very well, but now the slide is gone. Yeah. Okay, it's okay now.
Okay, excuse me.
Please go on.
My presentation is Redo TAVI in 2026, current evidence, re-intervention strategies, and technical advance. So this is the growing need for TAVI re-intervention. TAVI has now become a standard treatment for patients with severe aortic stenosis. The ongoing expansion of TAVI into younger patients with long life expectancy will lead to an increasing number who outlive their transcatheter heart valves and will present with structural valve deterioration and requiring re-intervention. Recent data from the United States showed that in 2021, more than 47% of patients undergoing TAVI before age 65. It has also recently been shown that more than 1/3 of patients undergoing TAVI before the age of 75 will be alive 10 years later. This data suggests that a growing number of patients will be presenting with degenerated THVS and require re-intervention. So this is the mechanism of THV failure. According to the VAX3 definitions, the bioparasitic valve dysfunction includes structural valve deterioration, non-structural valve dysfunction, endocarditis, and thrombosis. And the structural valve deterioration refers to the intrinsic change in the valve, such as leaflets, fibrosis, and calcification, flare, or wear and tear. Structural valve deterioration can manifest as valvular stenosis regurgitation or both, and it is the most common cause of BVD in the THVs. So there are two procedures exist for TAVI re-intervention: redo TAVI or surgical TAVI explant plus SAVA. Redo TAVI will undoubtedly be the preferred treatment for THV failure due to both the age and the comorbidities in this high-risk patient population, and the more favorable outcomes compared to surgical explantation. However, redo TAVI pose specific anatomic challenges, including an elevated risk of coronary obstruction and the preservation of coronary axis and optimization of hemodynamic outcomes and long-term durability. Meanwhile, surgical explantation plus SAVA and will remain a vital option in specific groups, including those who with endocarditis with anatomic features that prohibit redo TAVI. So what is the contemporary landscape of TAVI re-intervention? In a nationwide retrospective analysis of more than 400,000 patients undergoing TAVI, 3,700 cases, that means the incidence is 0.9% of patients subsequently underwent re-intervention, and most of them undergoing redo TAVI. The annual incidence of TAVI re-intervention increased from 0.2% in 2019 to 0.3% in 2026. With increasing procedure volumes of both redo TAVI and TAVI explant. So recent data from the United States STS and the TVT registry showed that the number of both TAVR in TAVR and TAVR after TAVR increased, and the redo TAVR procedures in the United States reached 42,000 in will reach 42,000 in 2035, and thereby represent 15% of all TAVI cases. This is recently published in the Euro intervention of the TAVI registry just a few days ago, which provides a prospective multi-center evidence with SAPIEN 3. This study is a prospective multi-center international registry and aims to evaluate the 30-day procedural and clinical outcomes of redo TAVI using the SAPIEN 3 valve. The primary objective was prospectively assess the 30-day safety and efficacy of redo TAVI using the SAPIEN 3 valve, defined as THV implanted successfully and freedom from major complications at 30 days according to VAC3. As you can see, a total of 143 patients included in this study, and most of these patients, the index THV was core valve or evolute, followed by SAPIEN and accurate neo valve. This is the index THV. The most common failure model was isolated regurgitation, accounting for more than 48%, followed by stenosis or mix. The THV failure mechanism was structural valve deterioration, accounting for more than 90% of cases. The mean time to re-intervention was 5.9, 7 year and 5.6 year for core valve, SAPIEN, and accurate valve. This is with VAC3 device success of 95%, and the 30-day mortality was 7.5%, stroke was 0.7%, and pacemaker requirements 6.3%, and moderate PVL just 0.9%. So the overall outcomes were encouraging. The incidence of procedural complication includes coronary obstruction was only 1.4%. So this is about the hemodynamic changes after redo TAVI. Redo TAVI significantly improved the valve hemodynamics, with the mean gradients decreasing overall of 12 millimeter mercury, and a significant reduction for patients with aortic stenosis from 45 to 16 millimeter mercury. The conclusions: redo TAVI using the balloon expandable SAPIEN 3 platform demonstrated high procedure success, accompanied by low rates of mortality and stroke within 30 days, as well as a very limited occurrence of coronary obstruction. The meaningful hemodynamic improvements were achieved across diverse anatomies and index THV types. These findings support redo TAVI with balloon expandable SAPIEN 3 platform as a safe and effective heart team guided re-intervention strategy, while also providing a contemporary benchmark of early outcomes to guide the lifetime management of patients with aortic stenosis. This is another evidence from the TVT registry, which is published in Lancet 2023, which provides the real-world evidence with balloon expandable valve. The STS TVT registry study evaluated redo TAVI with balloon expandable valves and compared outcomes with propensity-matched native TAVI patients. For each group, include about 1,300 cases. The analysis focused on the outcomes of redo TAVI with balloon expandable valve irrespective of type of valve used during the index TAVI procedure. The index TAVI procedure used the THV type included balloon expandable valve about 38% and the non-BEV about 60%. The key finding is there is no significance between those two groups with respect to the procedure complications and the death and stroke at 30 days or 1 year. The rates of procedure complications of redo TAVI were very low, include coronary obstruction only 0.3%, intra-procedure death only 0.6%. Controversial to open heart surgery is 0.5%, and which is similar to the native TAVI. So this is hemodynamic changes after redo TAVI or TAVI for the native aortic stenosis. Both groups, the hemodynamic was significantly improved with higher residual gradients after redo TAVI. About the moderate to severe PVL, at 1 year, there was no significance between these two groups. The function status for both groups were improved from the baseline. The KCCQ was just slightly higher in native group, but the directions of benefits were consistent. So the conclusion is redo TAVI with balloon expandable valves effectively treated the dysfunction of the index THV with low procedure complication rates and death and stroke rates similar to those who, with a similar clinical profile and predicted risk undergoing TAVI for native aortic stenosis. Redo TAVI with balloon expandable valves might be a reasonable treatment for failed THV in selected patients. There are another two registry studies include Transit Registry and the Global Redo TAVI Registry. Both of them showed that redo TAVI with a favorable or high procedure success and acceptable 30-day or 1-year mortality. So what is we know? Overall, this 4 registry studies have demonstrated that redo TAVI is feasible and effective in appropriately selected patients with high procedure success and favorable early outcomes. Outcomes are strongly influenced by the baseline clinical risk, failure mechanism, and anatomic suitability. What remains uncertain is the only prospective registry to date is the RE-TAVI, which is relatively small sample size, limited to short-term outcomes, and evaluates just the SAPIEN 3 valve. The retrospective studies remains unvulnerable to selection bias with heterogeneous indications and substantial representation of early re-intervention, the long-term durability, such as valve hemodynamics, coronary access, and the feasibility of future re-intervention remains unknown. So this is a redo TAVI versus TAVI explant, the comparative outcomes, the explant or redo TAVI registry, which is published in 2023. This study is a multi-center international registry for patients who underwent TAVI explant or redo TAVI for THV failure between 2009 and 2022. A total of 396 patients undergoing re-intervention for THV failure. Of these patients, more than 200 cases was assigned to redo TAVI, and the remaining 180 cases received TAVI explant. The primary outcomes include cumulative mortality and the in-hospital 30-day 1-year mortality after re-intervention. A total of 0.6% patient underwent re-intervention therapy. The median time from the index THV to re-intervention was significantly shorter in the TAVI explant group versus that in the redo TAVI group. As for the indications for re-interventions, TAVI explant patients had more patient prosthesis mismatch and the delayed valve migration, while as the redo TAVI group had more structural valve deterioration. When compared to the redo TAVI explant had higher 30-day and 1-year mortality and the similar strokes rates between those two groups. But on landmark analysis, mortality was similar between those two groups after 30 days. So the conclusion is TAVI explant had a short median time to re-intervention with less structural valve deterioration, more patient prosthesis mismatch, and similar PVL rates compared to redo TAVI. TAVI explant had higher mortality at 30 days and 1 year, but similar rates on landmark analysis after 30 days. So this is just a summary of the prior published registry studies. And all the studies showed that a higher in-hospital mortality and 1-year mortality in TAVI explant plus SAVA. The reasons for higher TAVI explant mortality include high baseline surgical risk and comorbidities, the presence of infective endocarditis, and the need for complex surgeries. This is recently presented at the New York Valves of the comparative outcomes from the Medicare analysis, which is a nationwide real-world experience evidence. This study aimed to characterize the real-world incidence, patient characteristics, and outcomes of all post-TAVI re-interventions using the dataset from the Medicare beneficiaries within the guideline recommended age groups. This study included more than 4,400 cases. As you can see, the cumulative incidence of post-TAVI re-intervention at 10 years is only 2.3%. This figure shows the trend of post-TAVI re-intervention. Both TAVI, redo TAVI, and TAVI explant up trending. For the TAVI explant is steady for 44 to 50%. This is the baseline characteristics. You can see pre-matching the redo TAVI group patients were older and had more comorbidities than that of the TAVI explant group. This is the Kaplan-Meier analysis, unadjusted survival after re-intervention. You can see redo TAVI group had advantages over the TAVI explant group during the short-term follow-up. However, after these two curves just crossed at 1.8 years. After that, this TAVI explant group had more advantage in survival over redo TAVI group. Even in patients without endocarditis, the TAVI explant group had more advantage over redo TAVI group. This is adjusted survival and risk after re-intervention. These two groups crossed at 1.8 years. After that, TAVI explant group had more survival advantages. This is the risk for TAVI explant. You can see after after seven months, the hazard ratio for TAVI explant becomes less risk than that in the redo TAVI group. This is stratified by age and at the time of index TAVI procedure. As you can see, in patients who are younger received the TAVI procedure. For patients with age 65 to 70 years, the TAVI explant group had more advantage over redo TAVI. So how about the cumulative incidence of second re-intervention? That means maybe the third procedure after redo TAVI or both TAVI explant. You can see the redo TAVI group had more incidence of re-intervention. So that means the TAVI explant group may freedom from the second valve re-intervention compared to the redo TAVI group. So conclusion is post-TAVI re-intervention remains infrequent long-term. Both redo TAVI and TAVI explant are steadily increasing TAVI explant is associated with improved long-term survival and freedom from the second valve re-intervention when compared to redo TAVI group. These findings inform future strategies for re-intervention, particularly in patients who are younger. This is a nationwide Medicare analysis just published in the Analysis of Thoracic Surgery. This study aimed to assess the long-term outcomes of redo TAVI versus TAVI explantation for bioprosthetic valve dysfunction after TAVI. Patients who undergoing aortic valve re-intervention after index TAVI between 2012 to 2020 were assigned to redo TAVI or TAVI explantation group. The primary outcomes were 5-year mortality. And the key finding is this study include more than including 1,170 cases undergoing re-intervention after TAVI, and 71% patients underwent redo TAVI, and the remaining 29% underwent TAVI explant. The redo TAVI patients were older and more often female and had higher comorbidity scores. As you can see in the Kaplan-Meier curve, after the redo TAVI group just had advantages in 30-day and 90-day mortality. But the KM curve estimated cumulative mortality was lower in TAVI explantation at 6 years and 5 years. So although redo TAVI showed an early advantage, the survival curves crossed at about 9 months. After that, the mortality remained consistently lower in the TAVI explant group throughout the whole follow-up. So what reason? They also said that redo TAVI may be unable to address certain elements of bioprosthetic valve dysfunction, such as severe PVL and severe patient prosthesis mismatch. So the conclusion is, although redo TAVI showed lower short-term mortality, but the long-term outcomes favored TAVI explantation. This finding suggests that for patients with TAVI failure, there is a subset of patients who could benefit from TAVI explantation over redo TAVI. These findings support an individualized approach to bioprosthetic valve dysfunction and highlight the need for prospective trials to guide lifetime management strategies for aortic stenosis. So we should interpret the outcomes in the context of selection bias. For the redo TAVI pathway, typically selected when the anatomy is favorable and the repeat transcatheter intervention is technically feasible. So the lower early mortality is consistently observed in registry studies, while long-term durability, while hemodynamics, coronary access, and the future re-intervention remains unresolved. As for the TAVI explant pathway, typically reserved for patients in who redo TAVI is not feasible, or would provide an incomplete solution, including those who with endocarditis, severe PPM, and severe PVL, prohibited coronary obstruction risk, or unfavorable root anatomy. So the higher early mortality is expected. The registry comparison should not be interpreted as direct evidence for procedure superiority. There are 2 ongoing clinical research in redo TAVI. The ReValve study, which is an investigator-initiated multi-center European prospective observational registry that will recruit 300 patients undergoing redo TAVI with SAPIEN 3 or Evolut valve for any failed THV. The primary endpoint for 30-day procedure success and 1-year freedom from mortality, stroke, and valve or procedure-related hospitalization, according to the VAC3. The follow-up data is 5 years. There is another study named RESTORE will recruit about 225 patients in 48 centers in the United States undergoing redo TAVI with a failed SAPIEN or Evolut valve treated with either a SAPIEN or Evolut valve as the second THV. Oh, there was another news just issued from the New York Valve 2026. There is a redo type best practice just published in the JACC intervention, which is from a heart and valve co-laboratory framework for TAVI in TAVI planning. And these two papers present a step-by-step approach, including clinical, anatomical, and technical aspects in the pre-procedure planning, technicals, and post-procedure care, right, in very detailed. How about the technical advantages advance in redo TAVI for the coronary protection? There was a detailed description of coronary protections published in the AGC and Structure Heart. Also, there's a new advance in the leaflet modification. As we know, the basilica usually is most frequently used for the leaflet modification. However, although the successful use of basilica has been described in redo TAVI procedures, the bench modeling suggests that it may be less effective due to the reduced display of the lacerated leaflets, primarily as the result of the constraint created by the indexed THV frame. So there was another technique just published in the CCI about the unicorn. The unicorn procedure in which THV is implanted within the leaflet that threatens the coronary artery after leaflet perforation and the balloon dilation is likely to be more effective than the basilica for leaflet modification for high-risk redo TAVI. A summary. Large registry studies support the feasibility, safety, and effectiveness of redo TAVI, while the prospective multi-center re-TAVI registry provides contemporary evidence within the SAPIEN 3 valve platform across diverse failed THVs. Redo TAVI is effective, but only in appropriately selected patients in carefully selected patients undergoing comprehensive CTA assessment and heart team evaluation. Redo TAVI achieves a high procedure success with favorable early mortality and stroke outcomes. Redo TAVI may offer less invasive re-intervention pathway, whereas surgical explantation plus SAVA remains indispensable when endocarditis, severe PPM, or unfavorable coronary or root anatomy. That's all. Thanks for your attention.
Thank you, Dr. Tang, for your comprehensive review about the lead tower in 2026. And there are many data about the lead tower is comparable with the TAVI explant. For some patients, the short-term outcome is better in real situation. However, considering the very old age or high risk profile of the recalled patient at the tower, the head-to-head comparison between surgery versus lead tower would be not feasible for the for long time. So making a good data and good selection of the treatment modality would be very important. I have a question about the coronary obstruction risk. The coronary obstruction risk would be the key concern in TAVI selection or the selecting of the valves and strategy. Can you please share your strategy or what do you consider when you consider the TAVI lead TAVI procedure of the coronary evaluation and protection?
Thank you very much for your question. For coronary protection, which is just right in very detail in the AGC or just published in the JACC intervention, there are many technologies can be used, but usually we use the chimney stent procedure. But for patient, first we need to perform a detailed pre-procedure planning. For example, we need to assessment the coronary risk plan, near scout plan, and any other other risk factors. For example, for patient with a high risk of coronary obstruction, usually we use the chimney. For some patients, we need to do Basilica or Unicorn or both of these techniques. I think this is it is hard to describe in very few minutes, but Dr. Tang and many experts has published published their consensus statements just in the JACC convention and writing in very detail. I think I can answer your question. Thanks.
Okay. And any other moderators and panels have a question or comment? Okay, thank you for your comprehensive lecture. Then we can go on. And Professor Guo, can you please introduce the next speakers?
Okay, the next speaker is Dr. Wei Xianyin from Chengxin General Hospital. His topic is transcatheter valve for field surgical aortic and mitral prosthesis. Welcome, Dr. Yin. Please.
Okay, can you see my slide?
Yes.
Okay, it is my great pleasure to share with you transcatheter valve for failed surgical aortic and mitral bypasses. I'm Dr. Yin from Taipei. As we know, over the past 2 decades, the use of a surgical aortic bypasses for treating aortic valve disease has increased remarkably comparing to the mechanical valve, largely because this approach helps patients to avoid lifelong anticoagulation. However, with time, bypassing valve dysfunction is a well-recognized complication, no matter with surgical or transcatheter valve. Comparing to the reduced surgical aortic valve replacement, as demonstrated in previous talk, also, the VIV TAVR is associated with lower early mortality, morbidity, and the length of stay, comparing to reduced SAVR. However, this benefit become diminished after 30 days and 1 year. And after that, the result favored reduced SAVR. So until now, the guidelines still recommend, although it supports TAVR for failed surgical aortic bypasses, it should be done at high risk or prohibited risk for repeated SAVR. Nevertheless, as up to 10% of surgical bypasses fail by 10 years, we can estimate that in 2035, the volume of TAVR in SAVR will be increased remarkably. In doing valve-in-valve TAVR, there are 2 major concerns. Firstly, the coronary risk, and secondly, the valve-in-valve the hemodynamic performance. We all know that in early registry demonstrate that pre-existing severe PPM, device malpositioning, or the use of balloon expandable Edward valves are associated with higher rate of PPM and increased post-procedure pressure gradient, especially in small surgical aortic annulus, which can be translated into poor short-term and long-term outcome. In our own data, we have performed more than 100 cases. This was analyzed with an amount of 89 patients. As you can see, if the surgical valve was small and without bypassed valve fracture or valve modification, BEV implantation into a small surgical valve significantly increased the risk of patient-process mismatch and leading to high residual gradient and poor hemodynamic result. Bypassed valve fracture or modification in valve-in-valve TAVR can fracture or remove the rigid surgical ring. Increase EOA allow further THV expansion, so as to in this way it can reduce residual gradient. However, there are controversies whether we should do it pre-implant or after implantation. In this report, pre-implant BVF may result in acute AR and hemodynamic compromise. So we have two options. If we choose to break or modify the valve afterward, it carry a risk of THV migration or embolization. However, it can avoid acute AR. On the other hand, if we do pre-implant BVF, it is easier to implant self-expanding valve with less size mismatch and can confirm successful fracture before the valve implantation. However, the risk of acute AR is higher. Given that the BEV in small surgical valve without BVF is considered the least favorable option. So in our center, we start from the very beginning to do BVF before implantation of SEV. We saw that this may represent the optimal strategy for VIV TAVR in smaller valve. This approach not only improves the valve expansion and the hemodynamics, but may also enable the implantation of a larger SEV. This is a recently reported aggressive off-guidance post-dilatation in self-expanding valve, showing that if you dilate the valve afterward aggressively, it might lead to leaflet damage and premature valve failure. So, as I said, ever since 2018, our team started to do pre-implant BVF plus SEV in small surgical valve with a true ID of less than or equal to 21 millimeter. This consists of our VIV cases, 78%. As you can see, we have done 35 such cases, and 2 of them using BEV, and 33 patients using self-expanding valve. As you can see, after the BVF or BVM, the hemodynamic performance was significantly better, and the device success rate was also better in patients undergoing BVF or BVM. At 30 days, the pressure gradient and EOA are numerically better in this group, comparing to those patients without BVF or BVM. But you should bear in mind that in patients without BVF or BVM, some of them are large surgical RT valve patients. This is a typical case. This patient underwent TAVR in SAVR with the use of 23 millimeter Sapien XT in 2016. However, at that time, we don't have the concept of BVF or BVM. So the procedure was end up with a significant residual pressure gradient of 25. 8 years later, the valve failure. As you can see, we have to redo TAVR for this patient. That means a TAVR in SAVR. But this time, we did pre-implant BVF first, using a 22 millimeter balloon. After that, we can use a 23 millimeter FX with success and result in a significant better hemodynamic performance of a residual gradient of only 7. In our series, we also follow up the patient with a median follow-up 3 years. As you can see, those group with BVF or BVM can have a better hemodynamic performance. Sometimes you may either choose a larger SEV, and this result in a better long-term mortality benefit. Although in multivariate analysis, it shows that STS at baseline and the 30-day functional class are still the predictor of long-term MACE, but you can see BVF or BVM can improve the outcome with a borderline significance. Everyone would ask me how to avoid acute AR after pre-implant BVF or BVM. This is the approach our team used. You can use the protective BVF. That means you place 2 wires, parallel wires in LV, one for ballooning and the other for THV implantation. In this way, you can immediately implant the valve after ballooning. After BVF, you can withdraw the balloon and the wire and advance the THV standby in the ascending aorta and immediately deploy it. In this way, you can safely perform the procedure and mitigate the hemodynamic compromise. The other risk is a coronary risk. As we know, the coronary risk comes from sinus sequestration or coronary ostial obstruction. This is especially true for external mounted surgical valve. For this patient, if the patient's sinuses are effaced or the patient has a narrow STJ, the patient are at a high risk of coronary obstruction. For these patients, we need to protect the coronary with various techniques or devices. This is the basilica procedure. We traverse the leaflet, lacerated, and then deploy the valve. Finally, you can see the patency of the coronary was preserved. Now we switch to transcatheter mitral valve-in-valve and valve-in-ring for failed surgical bioprosthesis. As of 2025, these 2 procedures have been widely used. From the very beginning, the landmark study of a mitral trial demonstrated that this procedure can safely be done in patients who need it. Until 5 years, the valve-in-valve result was really good, but the valve-in-ring and the valve-in-mark was not so good. However, even so, this approach significantly lower 1-year mortality, especially with the use of transcatheter approach. And there is a temporal shift toward increased use of transcatheter approach for mitral valve-in-valve or mitral valve-in-ring, reflecting the maturity and the experience of operators with TS mitral valve-in-valve or valve-in-ring. Our center started to do transcatheter mitral valve-in-valve and valve-in-ring very early in 2016. But at that time, we did the transapical approach. Ever since 2019, we switched to transcatheter approach. Until now, we have done 80 cases. As you can see, no matter transapical or transcatheter, the result was similar. And in our patient group or database, valve-in-ring and valve-in-valve also have similar outcomes, although the valve-in-valve is better a little numerically. In doing mitral valve-in-valve or valve-in-ring, you should firstly identify the surgical bioprosthesis and the feasibility of the procedure. There are many kinds of ring and valves. You should identify them beforehand. Fortunately, nowadays we have the app. So you can choose the size of the valve and choose the devices according to the app. And furthermore, you can choose the appropriate THV and then identify whether the valve or ring can be modifiable or fracturable and the position of the implant. The major concern of mitral valve valve and valve and ring are LVOTO. Also, there are two mechanisms, fixed obstruction of the leaflet and the dynamic obstruction because of the Bernoulli effect that draws the anterior mitral leaflet toward the interatrial septum during systole. To overcome this, you should bear in mind that the porcine processes are different from the bovine. The porcine usually have a shorter leaflet, and the bovine have a longer. So all these can be estimated or assessed from pre-procedure CT, which is of paramount importance. There are many factors that may affect LVOTO. Some of them will present in combination in the same patient. Some of these mechanisms can be overcome by leaflet modification, but some of them have to be done with the use of septal ablation or septostomy procedure. This is the so-called leaflet modification Lapun procedure. You can do it via base to tip or tip to base approach. The tip to base approach is much simpler. So we use more, very often. This is a typical case. You traverse, you use the astato wire to make a heavy loop, and then you pull the wire on both ends, which cause the wire to impinge on the anterior mitral leaflet. Then you can apply electricity and cut the anterior mitral leaflet. After successful cutting, you can see a new regurgitation. The intraoperative T can also demonstrate very clearly the successful cut. To our experience, if the near LVOT is larger than 200, in mitral valve valve, the procedure can usually successfully be done without Lapun. But if it is less than 200, you should do Lapun. And if the near LVOT after Lapun is greater than, is between 100 and 200, the result will be okay. But if after Lapun, the near LVOT is still less than 100, the patient still carry a high risk of LVOTO. So you might need adjunctive strategy or reduce SMVR. This is our cases. In mitral valve ring, the scenario would be even difficult because some of the patients have a very long anterior mitral leaflet. If the leaflet length is longer than the summation of distance of the bioprocesses protruding in the LV plus the frame to the septum distance, that means you still have a significant long residual distance, leaflet length inside the LVOT. The patient might still get LVOTO even you have done Lapun. This is our experience of 10 cases of mitral valve ring. Because the anterior mitral leaflet of the mitral valve ring case was not excised, as you can see, if it is really long, longer than 3.5 after this kind of calculation, the patient are at high risk of LVOTO if even though the Lapun was done. You may also try other way to do leaflet modifications, such as Buttman. This is the multi-center trial of 83 cases showing that the approach can successfully be done, and the result was really good with acceptable acute complication. For those patients, you need to do Lapun, but the residual near LVOTO was still less than 100, you may need septal reduction therapy. That means you should do alcohol septal ablation or sesame myectomy, etc., to reduce the LVOTO risk. For this left side procedure, we strongly recommend to use cerebral protection because during electrosurgery, as you can see, many cauterized particles can be captured by the cerebral protection device. We also know that in doing transcatheter mitral procedure, the septal puncture is mandatory. You have to choose a good position, and during deployment, the device positioning is also important, especially for the mitral valve and ring cases. This is a typical case of mitral valve and ring. As you can see, because the ring is a saddle shape, and it is difficult to localize the implant, the THV. So the first valve was end up with a too high implant. That means the valve was too atrial. So we have to fix the paralytics with a second valve implantation. We also found that if you can do a pre-dilatation, that means to modify the surgical ring, you can make the saddle-shaped surgical ring become flattened after balloon dilatation. In this way, you can better appreciate the implantation depth during implant and improve the procedure success rate. Also, we have some small surgical valve need to be break before implantation of a larger valve to avoid PPM. This can also be done in the mitral position. And in some patients with concomitant paralytics, we can use both occluder device and the THV to fix the both pathologies. In some patients, they are challenging valve crossing. So in this way, you can use Landerquest, you can use AV loop, or even bilateral approach using the small apical puncture to pull out the wire for stabilization of the whole system. All this can be done case by case. So in conclusion, transcatheter valve is a valuable option for patients with failing aortic and mitral bioprosthesis. PPM is more common in VIV TAVR, especially in patients with small surgical valve. BVF and BVM can help to mitigate the complication. Pre-procedure CT is also mandatory to estimate the coronary risk. And in high-risk patients, you may need different modification. Also, transcatheter mitral valve in ring and artery valve can be done, but the mitral valve in ring is more difficult because of the anatomy and the surgical bioprosthesis configuration. However, with ongoing improvements in addressing procedure challenges, I think in the future, the valve-in-valve procedure is expected to increase and reflecting the maturity and the experience of the operators. I thank you for your attention.
Thank you very much, Dr. Yin. Very nice presentations. I have a small question about TAVR VIV. In China, we have many patients with very small prosthesis. I want to know how do you select balloon for BVF and how to select the size of the TAVR valve. You just after BVF just increase the size, or you can select the valve according to the annulus before the TAVR procedure. Thank you.
Well, for small surgical aortic valve, which is breakable or modifiable, you can choose a balloon size 3 millimeter more than the internal diameter of the surgical valve to break it or to modify it. After that, you can choose sometimes even a larger size of a THV. In this way, you can have a better hemodynamic performance afterward. So that's the approach we did now.
If the surgical valve is very, very small, but the annulus, the native annulus is very, very large. So I select the TAVR valve according to the surgical valve or the native annulus.
I think you can, in that scenario, you have already implanted a small surgical valve. So bioprosthetic valve fracture is doable. So you can break the surgical valve 3 millimeter with a 3 millimeter larger balloon and size the new THV based on the balloon size instead of the surgical valve size.
Okay, thank you.
Can I ask a question about the mitral valve procedure?
Yes. Yes.
And first is what's your threshold for the leaflet modification therapy? And for mitral valve, Lampoon or Batman, what do you think would be the better choice?
Yeah, for mitral valve, if the new LVOT size was more than 200, you just do it without difficulty. If it is between 100 and 200, then you should do Lampoon. If the residual new LVOT is larger than 100, that would be okay. But if you estimate, even after Lampoon, the new LVOT size is still less than 100, you may need septal reduction procedure beforehand or afterward. That's for the VIV scenario. But if in the VIR, valve in ring scenario, because the anterior mitral leaves play a significant role, if the anterior mitral leaf length is longer than 2.5, saying you should do Lampoon. But it is more than 3.5, or as our calculation, the residual length is really long, then it still carry a risk of LVOTO because of the dynamic force sucking the anterior mitral into the LVOTO. So in that case, you should also do a septal reduction procedure concomitantly or before or after.
Okay, thank you.
As a Batman, we have done one or two, I remember. I think it's a good procedure. Yeah, something like the unicorn and the basilica, you know.
Okay, thank you again. Dr. Cassell, Dr. Cassell,
yes.
Can you introduce the next speaker?
Sure, thank you, Doug. So it's a great meeting. Sorry for joining you late, but we'll have our last speaker, Dr. Li Yan. She is actually the director of the Department of Cardiology from Chengdu Hospital, Air Force Medical University, very wide published in the field of structural heart intervention and also basic science, and top cited scientist. So today she's going to share with us her case experience in therapy by different approaches in patients with pure aortic regurgitation. Dr. Li, please. Dr. Li, are you with us?
Dear everyone, it's my great honor to attend the online Asia Structural Heart Disease Conference. My title is Advances in Interventional Therapy for Pure Native Aortic Regurgitation. I'm Dr. Yan Li from Department of Cardiovascular Medicine, Chengdu Hospital. I will mainly focus these 5 section to introduce the advances of AR tower. As we know, the AR carries a massive population burden and extremely poor prognosis under conservative management in China. The number of patients with AR in China is much higher than that of patients with AS. The prevalence of AR stands at 3.1% among people aged 65 to 74, and 17.1% for those over 70 years old, and approximately twice that of a severe AS patient. Patients with severe AR classified as New York classified 3 to 4 have a mortality rate of over 70% within 3 years under conservative treatment. The number of TAVR procedures keeps rising, yet AR therapy is severely insufficient. The volume of the TAVR process in Chinese mainland saw a continuous increase from 2010 to 2025. The number of TAVR exceeded 18,600 in 2025, representing an 8.1% year-on-year growth compared with previous year. Domestic TAVR therapy is mainly indicated for AS. Only 57.7% of patients with severe AR receive relevant treatment. There are 5 core technical challenges restricting AR TAVR applications, all stemming from the unique anatomic traits and AR featuring large aortic structure and scale leaflet calcification, plus a shortage of a special transcatheter valve for AR patients unsuitable for TAVR. AR disease represents a long asymptomatic phase in the early stage. There are several pathogenic factors of AR and elaborates its progressively trajectory, which features a prolonged asymptomatic compensatory phase before patient advances to decompensated heart failure with impaired left ventricular function. Mild to large AR progress rapidly to decompensation, making timely clinical intervention is crucial. According to ASE guidelines, TEE serves as a gold standard for grading aortic regurgitation through integrated quantitative, semi-quantitative, and quantitative indicators, including RV volume, RF, and EROA, yet its inherent imaging limitation for eccentric regurgitation necessitates supplementary TE or CMR to ensure accurate clinical risk stratification and treatment decision-making. Real-world China DVD study showed that a severe asymptomatic AR has a much lower intervention rate, about 57.7% than AS, and identified 3 key clinical root causes for widespread AR undertreatment, remaining clinicians to address echocardiography limitation in mirroring, overlook of asymptomatic patients, and delayed intervention for symptomatic cases to improve patient survival outcomes. 2019 clinical study of 232 AR patients quantified the prominent failure rate of multiple routine TTE quantitative metrics for moderate severe AR patient caused by poor acoustic windows and extrinsic regurgitation jet, clinically highlighting that over reliance on echocardiography alone will lead to inaccurate AR grading and subsequent delayed optimal intervention. Combining the 2000 ACC/AHA valve heart disease guideline flowchart and cohort follow-up data, this slide demonstrates that asymptomatic severe AR patient carries a sharply elevated risk of death or valve surgery compared with moderate AR, clinically reminding physicians not to neglect close surveillance and early intervention for symptom-free severe AR patients before irreversible ventricular damage development. Second contributor to undertreatment is conservative therapy fails for patients with severe AR. AR patients have over 90% 5-year mortality. Elevated mortality risk warrants early intervention before cardiac structure and function deteriorate. Timing of intervention for AR focus on cardiac dysfunction and left ventricular dilation. Compared to the class 1 and 2 guidelines recommendation of ACC/AHA and the ESA ERECT for aortic valve replacement in AR, which uniformly prioritize symptoms, left ventricular systolic dysfunction with divergent left EF cutoffs and critical left ventricular dilation threshold as core intervention timing criteria to guide clinicians in standardized early valves TAVR severe before permanent myocardial injury occurs. The survival rate data show the severe AR patient with New York Heart classification 3 to 4 heart failure face over 70% 5 years mortality and explains that routine TTE EF overestimated actual forward cardiac output due to regurgitation backflow, alerting clinicians not to delay early intervention solely based on seemingly preserved ejection fraction readings. The JACC cohort data providing that the index left ventricular and systolic diameter threshold of 25 millimeter set by guidelines marks a sharp surging in 5-year mortality risk for AR patients, emphasizing that LVESD index normalized to Bordeaux surface area better identifies hidden distal left ventricular dilation risk in slim patients than raw LVESD value alone to guide timely valve intervention. This multi-center retrospective study survival data demonstrate that moderate AR patients with LVESD index over 25 millimeter carry a higher 2-year mortality rate, about 34.3%, than severe AR patients with normal LVESD index, proving LVESD index is a superior risk stratified marker that guide clinicians to prioritize early intervention for any AR patient presenting significant left ventricular remodeling, regardless regurgitation severity grade. 2025 ES guidelines has some key updates. For a symptomatic patient with severe AR, surgical indication are listed based on left ventricular function parameters, including EF value, left ventricular and systolic diameter index, and the left ventricular and systolic volume index, and new reference such as LVESV index over 45 milliliter measured by CMR are also added. Overseas guidelines and Chinese domestic expert councils provide clear Class 2A recommendation criteria for TF tower in high surgical risk symptomatic and asymptomatic severe PAR patient with adverse left ventricular remodeling markers, offering standardized minimum invasive treatment alternative for in-operate AR patients for surgery in China. Before 2026, there were many off-label tower devices for the treatment of AR patients were used. Off-label TF tower with commercially available valves has been exploited in patients with AR, and outcomes suggested that it may be a feasible option for those at high surgical risk. In off-label situation, we usually use non-coronary sinus pivot implantation that is called NCPI method to make THV stable. NCPI verify principle including the pass criteria, depth and morphology assessment at NCC pivot. There are upgrading and iteration of AR devices. This picture shows NCPI method. And also we have upgrading and iteration of AR devices. We now step from off-label use to on-label era. There are many domestic dedicated devices for AR. Some of them are separate locator design, and some of them are integrated locator design. Design essential of dedicated AR devices, including sufficient valve dimensions, leaflet capturing positioning element to overcome the difficulties of a non-calcified and non-anchoring anatomy. And the third, rapid pacing during release to reduce the suction effect. The Align AR study laid the foundation for the application of valve with positioning key in AR. Triology Align AR showed all-cause mortality rate is about 15.4%, cardiovascular death 7.4%, and stroke rate 6.4% at the 2-year follow-up. Triology Align AR showed also mean gradient is about 8.7 to 4.2 milligram, EOA 2.8, and the PVL non-obtrusive counts about 95.5%, and the moderate PVL is about 4.5% at 2-year follow-up. Triology Align AR also showed the changes of left ventricular reverse remodeling at 2-year follow-up. And in China registry, we call it Alter AR China registry, provide further evidence for favorable post-operative safety and efficacy. The Alter AR trial demonstrated excellent clinical outcome in Chinese population. Alter AR showed 1-year all-cause mortality is about 2.6%, and only 12.1% new pacemaker implantation, and significantly lower than Align AR reported to 24%. Alter AR 1-year follow-up showed a significant improvement in cardiac function classes. This is the main procedure of dedicated AR devices. We call it a Terrace Trail. So, and then I will introduce several cases. Case 1, this is a separated locator designed G-valve in large annulus ART tower. This is a 65 years old male. He had chest tightness and shortness of breath for more than 1 month. And echocardiography showed severe AR and persistent atrial fibrillation and acute heart failure and cardiac function classes 2 to 3. So pre-tower CT analysis showed annulus as about 30.6 millimeter. It's quite large, and STG is 36.9 millimeter. And left coronary and right coronary height is okay. No coronary obstruction risk. We then prepare a 22 French large sheath and pre-shaped guide wire and preload G-valve 34 millimeter. That means largest size of this valve. Which is designated as a separated locator and THV. And we can see the scattered calcification in the aortic arc and the descending aorta. This is the procedure. We first put the pigtail catheter placed in the base of a right coronary sinus for angiography to determine the annular plane. And then the delivery system was advanced smoothly across the aortic arc under guidance of a light-borne sheath. The locators was designed separated, so the locators were positioned first in the aortic sinus, followed by arc pulling. So we can say the valve capacity were lowered, and angiography was performed to assess the extent of locator enlargement in the sinus. And we should use TEE and angiography to determine all the locator was in the different sinus. The guide wire were adjusted to improve coaxiality. Angiography confirmed the valve position and the implantation depth. Now, finally, the valve was released under rapid pressing. Okay, angiography showed an ideal valve position with stable deployment. The locking wire was disengaged, and the PEEK tube was withdrawn, and delivery system was removed. Finally, angiography demonstrated good valve position and complete disappearance of total regurgitation totally disappeared. And the post-operative echography showed very good result. No leak, no parallel leak, no gradient. Okay, this is case 2. Also a separated locator design, G-valve in AR tower in a very elderly patient. This is a female patient, 80 years old. She has intermittent chest tightness, shortness of breath, and palpitation for 9 years, worsening over in the past 8 months. And echography showed a severe bilateral enlargement and degenerative aortic valve disease with severe regurgitation, and also dilated ascending aorta, mild pulmonary artery dilatation, moderate mitral and tricuspid regurgitation. And the preoperative CT analysis showed the annulus is about 23.4 millimeter. STG is about 31.3, and the LVOT is 24.3. And left coronary and right coronary, no obstruction risk. And right femoral artery was selected as primary access route. We can say this is an old female patient, so the all the vessel quite small, and the narrowest diameter is about 6.1 millimeter. And then we can start the procedure. We still put the pigtail catheter placed at the base of the right coronary sinus for angiography to determine the annular plane, and then put the system smoothly. And the locator were positioned into the aortic sinus. The locator was positioned into the aortic sinus. During the procedure, we must adjustment and try our best to put the locator into the sinus. The delivery system was advanced across the arc to STG junction. The locator were positioned into the aortic sinus. Double check with TEE and angiography. And then evaluate the locator position, and then arc pulling, and then lower the valve capsule. Okay, angiography confirm the valve position and the implantation depth. And then release the valve under rapid pacing. Finally confirm stable valve position. Quite good result. This is the final and echography result. No paravalvular leak, no gradient. Okay, the last two cases show we use integrated locator design. We call it a torus trio in AR with large annulus about 30.2 millimeter. This is a female 72 years old patient. She had intermittent chest tennis and troughness of breath for 5 years. And echo showed degenerative aortic valve disease with moderate to severe AR. And slightly increased of CKMB and male. And the structure overview showed annulus quite large, is about 30.2 millimeter. STG about 37.4 millimeter. And mild tortuous of peripheral access route with acceptable inner diameter. And our strategy to select the large torus trio valve per annular and LVOT 6 millimeter plane measurement. Oversizing is about 4%. Okay, we first make a right sinus central angiography to identify the STG plane. And then we push the lung sheath and let the marker close to the STG plane. Okay, this is the marker already close to STG. And then we check the valve loading, whether good or not. And then deliver the valve along the guiding sheath until the two visualization ring overlap. And then retract the guiding sheath to the descending aorta. Dissociate the valve after bending the coaxial cable. And then ROA agitation at right center. Central marker tilts to lesser curvature, confirming sinus coaxiation alignment. advancing the system into the sinus to capture the leaflet, advancing the valve into the sinus, slight fluttering of left sinus locator confirms the successful capture of left leaflet by the locator. And then super selective cannulation of left coronary sinus to confirm sinus engagement. And again, super selective cannulation of non-coronary sinus with appropriate insertion depths. After TEE again check, we can see the 3 locator are visible. This is a locator. And then verify the radiopaque ring lies below the annular plane. And then initiate pacing and deploy the valve. And the post-deployment angiography, we can see a very good result. And this is the final angiography, echography. No leak, no gradient. And finally, this is a 69 years old female. Chief complaint is 1 month exertional chest tightness. And again, echo showed moderate to severe aortic regurgitation. We can see a very big annulus. This is analysis of annulus and leaflet, no calcification. And LCA and RCA has good height, no obstruction risk. And peripheral access is quite good. So we choose exercise. For this patient, we choose M size. So this is a procedure. We again put the lung sheath and then check the valve and put the valve into the sinus. Again, we use different location to detect the locator, whether the locator into the different sinus. And again, according to the TEE, we can detect the different locator into the different coronary sinus. And finally, after pacing, we deployed the pacement, the valve. The final result is quite good. Okay, that's all for my today's lecture. Thank you.
So I guess Dr. Lee has finished her talk. So I'm sure most of us are very excited about the treatment of aortic regurgitation, but as Dr. Lee is not online, I guess we cannot ask her some questions about different device, especially there were actually some other device that is actually coming from mainland China, apart from the transfemoral J-valve and also the trilogy from the Western countries. So because of the time constraint, I would like to conclude today's section. So I learned a lot, although I joined later, but I know that earlier this morning we have Dr. Jonathan Yap from Singapore sharing with us the alternative access in transcatheter for TAVI and also some other large bore access. So that was actually quite important in Asia Pacific. And then Dr. Tang has shared with us the new updates in the insight of TAV in TAV, to follow with Professor Ying from Taiwan, sharing us the different tips and tricks in transcatheter mitral and tricuspid valve and valve-in-wing procedures, which is going to be more widely adopted in different regions. I heard, for example, like the valve-in-valve procedure is recently get approved in a number of sites in Asia Pacific. And lastly, Dr. Lee has just shown us the new therapies for treatment of aortic regurgitation. So that was actually some of the very updated areas in structural heart intervention. So that's very fruitful morning. Thank you all for joining us, and thank you for all the panelists for joining this morning sessions on Sunday. Thank you very much.
Thank you. Bye.
Bye-bye.
Yeah.
Bye bye.
Bye-bye.